Hello and welcome to the BSG Trainees Podcast. My name's James Kennedy and I'm a gastroenterology trainee in the Thames Valley. Today's guest is Professor Siwan Thomas-Gibson. Professor Thomas-Gibson is Professor of Gastrointestinal Endoscopy at Imperial College London. She has been a consultant gastroenterologist at St Mark's Hospital since 2006 and is currently Dean of the hospital. Her clinical interests are in advanced endoscopic imaging and complex therapeutic endoscopy. After graduating from Imperial College London, she trained in gastroenterology and completed an MD in improving training and assessment in colonoscopy in 2006. She is passionate about endoscopy training and standards in colonoscopy and was chair of JAG, the Joint Advisory Group on Gastrointestinal Endoscopy, from 2017 to 2020. Welcome to the podcast.
Thanks, James. Thanks for having me.
Thanks so much for coming on. So, first of all, can you talk to us a bit about what inspired you to become a gastroenterologist?
That's quite an easy answer to that question. It was a boss that I had when I was what was then called an SHO in the early 1990s at Northwick Park Hospital, which is coincidentally where I've been a consultant for the last 15 years. So there was a superb gastroenterologist called Jonathan Levi, who was the senior gastroenterologist. There were only two gastroenterologists there at that time. And he absolutely loved the specialty. And post MRCP, I was a little bit lost as to what to do. I knew I quite liked a practical specialty. I thought about doing cardiology. I did a bit of medical ITU down in Brighton. But neither of those things really hit the note for me. And so I went to Jonathan, having been his SHO, I went back to see him for some careers advice. And I guess you would say he sort of took me under his wing and persuaded me, didn't take much persuasion, to apply for the registrar posts that were being advertised at that time. And it was an easy thing for him to do because he absolutely loved his specialty. He encouraged us as junior doctors. He was always enthusiastic about his patients. He was adored by his patients. And he was very, very supportive. So I think for me, gastroenterology was sold to me by him and his colleague, Meryn Jacina, who is still now one of my colleagues at Northwick Park.
Brilliant. And how about your route into endoscopy specifically?
So there's a quite easy answer to that question as well. As a junior registrar, like most, I think, I struggled particularly with colonoscopy. I enjoyed it as a practical part of the specialty, but I found it very frustrating to learn. And my early trainers, albeit that they were very keen and supportive, couldn't really describe to me what was happening during a colonoscopy. And I went to a BSG meeting. At that time, there were 2 BSG meetings a year. And I remember sitting in a presentation by, one of the senior endoscopists at that time, presenting the first data on the image guidance, or what's now known as scope guide, manufactured by one of the big endoscopy companies. And they were doing preliminary work at St Mark's on scope guide and how that could help colonoscopy. And it was one of those light bulb moments because it triggered 2 things. One, it showed me something about endoscopy and colonoscopy that made sense. And secondly, that there was research into how to teach a practical technique, which was mind-blowing, really. And following that, I went along to one of the first live endoscopy training courses at St Mark's, where there were just 5 or 6 of us in a small room that's now our research fellows office, and watched live endoscopy with this scope guide, and it suddenly made a whole lot more sense. And so I enthused about this and managed to get a research post after a part-time clinical post at St Mark's, and never looked back, I would say.
So that led to your MD, was that right?
That's right, yeah. So I guess I should give all credit to Christopher Williams, who's now retired, and Brian Saunders, who's now my colleague, they really were that inspiration and superb trainers and mentors. And I did my MD with Brian as my primary supervisor, and the late Wendy Atkin was my other supervisor for my MD at St Mark's. Yeah.
There's a common theme there, isn't there, from your SHO years, registrar years, and during your MD of inspirational people and mentors. And I know that's something you've taken forward as a consultant. Can you talk to us about your relationship with mentorship and how important you think it is?
Yes. So, I mean, those people that I've mentioned were, truly, inspirational, and they weren't formal mentors. I don't think any of them had done a BSG mentorship course, but they were the sort of old style mentor where I think if you're enthusiastic and show enthusiasm for a subject area or a research field, as anyone, but as in our case, as a junior doctor, senior people take to that because you show a degree of commitment and mutual interest. And I felt very well supported by the team at St Mark's at that time, including Wendy and Brian Saunders. And I suppose that's taught me in a way how important role modelling is, and how supportive you can be to people starting out their career, and how influential it can be, even in an informal setting. So probably about 5 years ago now, the BSG set up the mentorship scheme, and I was very keen to get involved in that. And so I did the training that was provided by the BSG, and the idea was particularly to support women in gastroenterology and provide mentorship for that. But of course, it's quite rightly branched out now, so it's broader than that. And over the last few years, I've had several, formal mentoring relationships with gastroenterologists, and more recently, a senior GI nurse in a senior leadership role. And of course, it's rewarding both ways. It isn't just the mentee that potentially gains from that relationship. The mentor definitely does as well. So I think that's been a fantastic innovation by the BSG, and one that I would encourage people to take part in, and hopefully they will continue.
And you've taken that passion for endoscopy training forward, and you've had a pivotal role in endoscopy training in the UK during your career. What have you enjoyed the most about the aspect of your job currently and your time with JAG?
Well, I think the best bit of my job has always been to provide, really high quality colonoscopy to patients. Colonoscopy is, in any situation for patients, anxiety provoking and potentially embarrassing. You have to take a bowel preparation with all the anxiety that entails. The actual procedure itself is, of course, very invasive. Patients are often coming either because they've been told they might have cancer, or they've got symptoms that they're worried are cancer, or other significant diagnoses. And a lot of my patients in particular have, conditions that predispose them to cancer. So they know they've got a cancer risk. And so trying to provide a service that patients feel willing to come for their procedure, and more importantly, return if they have to return, is really, really important. And so I have narrowed down my practice quite incredibly, to mostly being colonoscopy and certainly luminal gastroenterology. But I enjoy that focus that brings. I remember thinking back at Christopher Williams when I first met him, thinking, gosh, that's quite strange. He only really does colonoscopy. But of course, here I am, a couple of decades later, doing exactly the same. And that's because it is an infinitely variable and challenging procedure to do. It's a joy to teach it. So that's the other highlight. I've been teaching a Train the Trainers course this week with our senior fellows, and passing on that knowledge and enthusiasm is something that is definitely a privilege of my job. Regarding JAG, well, again, that was that was sort of almost icing on the cake, really, to be in a position to be able to, in some way, influence and support the fantastic work that JAG has always done for UK endoscopy was great fun. I really thoroughly enjoyed it. I was there for 3 years as chair of JAG, but prior to that, several years ago, I was the first subgroup training lead for the QAT group. And it's difficult to make changes. It's difficult to influence at sort of Department of Health or government levels or devolved nations for anybody in any specialty. But during my time in JAG, we were able to at least talk to those leaders and have some impact through either NHS England or HEE, so Health Education England and so on. So we were mixing with those people, with the GERF team, with CQC, and making sure that high quality endoscopy was seen quite rightly as being, an important aspect of healthcare in the UK. And of course, JAG has a fantastic international reputation, and so to be part of that was great fun and a real privilege.
That's really exciting. And from magnetic scope imaging right up to AI in colonoscopy, you've seen leaps and bounds in endoscopy and colonoscopy over your career. What do you think is the most important thing that has changed over the past 15 years, whether it's in colonoscopy training or the procedure itself or the technology? And then I guess the second part of the question, looking forward, what do you think the next 15 years will have in store for us?
So I've often asked this question. I've given it a lot of thought, and I would say, really, one of the main changes over the last 15 years or so has been certainly in the UK, the focus on developing high quality training and training methodology. And in fact, just on this course that we were teaching in the last few days, we were talking about the development of teaching and training and certification. And a lot of that I've been, lucky enough and really enjoyed to be part of. So, years ago when I trained, there was no JETS, there was no sign off. You were just given the go ahead when your boss gave you the nod. And so delivering high quality endoscopy for all patients really has changed leaps and bounds in the last 15 years with all of the certification processes that have been introduced, whether it's the DOPS or the DOPIS or the non-technical skills training framework. So all of those things I think have really changed endoscopy for the masses, because now every endoscopist has to go through that training and certification program. Of course, there have also been massive developments in the sort of therapeutics, like the development of ESD in this country, or full thickness resection devices, or POEM for upper GI, pathology. Of course, there have been massive leaps and bounds in the therapy that we can deliver, and that's really important and very exciting. However, doing a good diagnostic procedure well is what's important to a very large number of patients. And so for me, I think that's the biggest contribution and the biggest development over the last 15 years. And going forward, I'm not sure that artificial intelligence will replace that, not in the next 15 years. We still will be pushing scopes, I think, for the next 15 years at least. I mean, there are obviously developments like capsule and colon capsule, but they'll detect polyps, and I think in the next 15 years we'll have to still go in and get those polyps, as a human. But of course, AI, which is really exciting, and just coming on board so rapidly in terms of both detection of lesions and abnormalities and their diagnosis, and it's really exciting to see that happening. For those of us who are perhaps a little bit skeptical, I think the word skepticism is associated with being over the age of 40. You're bound to be a skeptic. So for those of us who are perhaps a little bit skeptical, we're seeing that it does work, and so I think AI is going to be a really exciting area. And I would be remiss if I didn't mention some of the work that Boo Hay at King's is doing, looking into sustainable endoscopy and a greener endoscopy. The stats for how environmentally unfriendly endoscopy is are really horrifying. So I really hope that in the next decade we can sort that out and make endoscopy greener, as well as using some of the newer technologies, and maybe the newer technologies will help with that.
That's really exciting that endoscopy is looking to become more sustainable and think about its impact on the wider world. Is that through things like water use with cleaning equipment?
Oh, everything from minimising the number of appointments that patients have to come to, so that they're not driving their cars to and from the hospital unnecessarily, that they're not having unnecessary procedures, to the waste that's involved every time you use a snare. For example, do you have to use different snares for different polyps? I mean, of course, the teaching is yes, you do, but can we think about that differently? Can we recycle parts of the snare? Are we able to use water, or is there sterile water? Is there a better way of doing it? But also even the most basic things like the empty box. When you take the last glove out of the cardboard box, are you making sure that you put that cardboard box in a recycling bin as opposed to in heaven forbid, the yellow soiled waste bins, which really are dreadful? Are we recycling where we can? So there's a whole piece of work that is now being led by, as I say, Boo Hay, based in King's, and there's a huge amount of opportunity there to try and make things greener. And I really hope, in fact, it'll be a plug because we're hoping to have a fellow soon. So if anyone is interested, do either get in touch with Boo or ourselves, because we are looking for fellows to take on that work in the form of an MD or PhD in the next year or so.
Excellent. So that's a really a combination between doing things that we already do better and then exciting new technology to look forward to. And for yourself, what would you? This might be a difficult question, but what would you say your proudest achievement is to date, either within or without medicine?
Oh, well, without medicine, I'm going to have to say my 3 sons, aren't I? And quite right. So I am a mum. I've got 3 children, grown-up children, really. Who are fine young men, and they've become that in spite of me, working very long hours for very many years. But I reckon that having a hard-working mum is a good role model for any young person. So that's definitely my proudest achievement outside of medicine. Inside of my career, I was made an Imperial professor, a professor of practice, just last year actually, and so that's got to be my proudest achievement, because it recognises the collective work that I've done really over the 25 years that I've been in gastroenterology and specifically in endoscopy. And it's particularly sweet because I trained at Imperial, so I started at what was St Mary's and became Imperial in 1986, a very long time ago, and then to get a chair there so many years later, really as a result of work that I've done with so many people, so many research fellows, so many people, largely at St Mark's, but also outside of St Mark's. That's definitely my proudest academic and professional achievement.
A real feeling of having come full circle.
Yeah, absolutely. The only way is down.
And in terms of kind of balancing family life and life outside of work, you've spoken very well on less than full-time training in the past. Do you mind speaking to how you found that throughout your career?
Yeah, it was absolutely essential. So I was less than full-time for the end of my registrar years, if I'm allowed to call them that. So from really when I started having kids until my youngest was, I don't know, went to senior school. So it was almost a decade probably as a senior registrar, and then as a junior consultant, I worked between 60 and 80% time. And during that time, I managed to do my MD and write it up, finish my clinical training, do my become a consultant, probably supervised 2 or 3 other MDs during the early years as a consultant, and did some of the other work with BSG and JAG as a less than full-time doctor, if not trainee. I was very lucky in that when I was a registrar at registrar level, there were very few female gastroenterologists, and therefore job sharing wasn't very easy to do. So most of us were supernumerary posts, which meant that we were seen as a funded extra pair of hands in whatever hospital that we worked in. And so, for example, I believe you're working in the Royal Berks. I finished my training in the Royal Berks, and I was an extra, senior registrar. So you're quite welcome at that level, helping out with clinics and endoscopy lists and so on. But it gave me the flexibility to get what I needed to finish my training. And I do recognise that that's not necessarily the same if you're in a job share post, these days. But it did allow me to have a family. I had a lot of help throughout my kids growing up, external help in terms of a nanny. But it did allow me to have children, to be involved in bringing them up, and a little bit of, school and mum life during the week, but also to progress my career. And I would have to say that being less than full time and being a mum of 3 kids, I can't say has hampered, my progression at all. I don't think, I got there a bit later than some, but I think it's just, it's been a fantastic journey, so I can't complain at all. But I think if you have the opportunity to do that, then I would encourage people, whether you're, a man or a woman, to do it. It'll only enrich your life, and it doesn't have to be forever. And as I say, I've gone back to being full-time now for very many years. So, it is possible to do that.
That's really good to hear. And what about, what are your loves outside of medicine? What do you do to wind down? And
well, we're very lucky. We live in the Buckinghamshire countryside. So I walk out of the back of my, house, or the front of my house, and then we're just, into the fields and the Chiltern countryside. So I walk with family, walk with friends. I do a little bit of jogging and running if I'm feeling a bit more energetic. And outside, well, within lockdown, that's been, a lifesaver. Outside of lockdown, then it's love of music and theatre, which I'm sorely missing, I have to say. Visiting family back in Wales, walking on the beach in Wales, is something that I've definitely missed. So it's the outdoors, really, but I don't run marathons.
And I guess so. We can't really not talk about avoid the elephant in the room of the COVID-19 pandemic. We're just reaching the 12-month point since the first case in the UK. In terms of the impact of COVID-19 on endoscopy in general, on colonoscopy, on bowel cancer screening, because I know that there's been a lot of work done on that. Could you tell us what your views are and your apprehensions surrounding that?
Oh gosh, yes, and I've got very mixed feelings about it. So at Northwick Park, as with your hospital, actually, Northwick Park was, I think it's well accepted now, one of the first, if not the first, and hardest to be hit. And with the first wave last February, so February 2020, and very quickly it became apparent to us that we were going to have to stop elective procedures because of the risk of bringing in patients for screening. We were still doing bowel scope, so flexible sigmoidoscopy screening at that time. And it just felt totally counterintuitive and unsafe to be bringing completely well people who have no symptoms into the hospital, when actually our department, myself included, had COVID and were really quite unwell. So endoscopy nurses and doctors, we were dropping, several of us, over the space of a week in March, went off sequentially. And so we couldn't actually deliver the service because we didn't have enough staff, but also it just felt wrong to be inviting people into the hospital. So I was, amongst a group of people in the UK who felt that we had to stop bowel cancer screening. The difficulty is that it's a juggernaut, and stopping it was actually quite difficult. And then restarting it was even more difficult. So we were ready to restart bowel cancer screening, perhaps before everyone else had, given us the go-ahead. And undoubtedly, Materacki has published on this recently. We haven't diagnosed as much cancer as we did this time, 2 years ago. So there are missing cases, and that's really worrying, both from the symptomatic side and from the screening side. And so undoubtedly the pandemic will have its effect going forward. We are back up now. We have recovered. I'm pleased to say we're one of the first units to fully recover our bowel cancer screening service. Bowel scope has obviously been paused. I think that it's been stopped, sorry. That probably would have happened anyway, I think. I think the COVID pandemic really just was the nail in the coffin, really, for that programme. But there are, as you'll know, there are plans to reduce the age for fit test screening. So those people, rather than patients, those potential screening patients will be offered a test. But we have got a backlog still. There's still a lot of catch up to do within the symptomatic service, and some services are still trying to recover for bowel cancer screening. So I don't think we had any choice. I think it is regrettable that we had to, reduce elective services. It wasn't just endoscopy, obviously. However, the BSG and JAG, and I can say this because I wasn't directly involved in either of these, but they responded in an incredibly timely fashion and in a really supportive way for units to deliver safe endoscopy, with guidance coming out, responding to the shifting sounds and the changes that have occurred and still occur, even a year on. So those professional societies and organisations have been instrumental in getting endoscopy back up and running. And, hopefully, along with the issues I was talking about with green endoscopy, it will make us, think harder about doing any unnecessary procedures. We've really got to focus on the patients that really need endoscopy and not repeat endoscopy unnecessarily. So I think there will be some advantages to the pandemic. It's just that we're still playing catch up at the moment.
In terms of a more resilient system and minimising unnecessary procedures, there are some other green shoots that will come out of this as well.
I think that's right. Yes, yeah. Training, of course, has as a trainee, I've got to say, for trainees, I think it has been a really challenging time, and a lot of endoscopy training has been put to one side, and I recognise that. But be reassured that, again, people in high places are focusing on that and trying to look at ways of accelerating training.
Thank you. And to leave off, if you had to pass on one piece of advice for an early career gastroenterology trainee or someone considering applying for a training post in gastroenterology, what would it be?
Can I have two pieces of advice?
Yes, of course. Yeah.
Okay. So my two pieces of advice, I think, would be to create or to seize opportunity. And that is clinically, as I've kind of alluded to earlier, muscle your way in on endoscopy lists if there's no trainee there, or in specialist clinics or what have you. Get involved with things like BSG or JAG or local trainee groups, because if you do that as a trainee, you will carry that on into your consultant career, and you can only benefit from that. So create and seize those opportunities. However, make sure that you do have a good work-life balance, and whether that's for a period working part-time or, making sure that you protect time at the weekend for family and friends and so on. That is really important because, it is, as they say, it is a marathon, not a sprint. You're going to be a consultant for a very, very long time. You don't have to get there, at a very young age. There's plenty of time to be a consultant. So make sure your work-life balance is healthy.
Sure, and thank you very much for joining us today.
It's my pleasure. Thank you for inviting me.